Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I want to welcome you to today's webinar. For those of you who may not know the PCC, we are an organization that convenes diverse stakeholders, including consumer groups, purchasers, health plans, clinician organizations, tech firms, and many others, focused on improving the nation's health by strengthening primary care. Today's discussion is focused on how GLP-1 treatments fit into a whole person approach to primary care. This is a very large topic, and we could dive into many different aspects of obesity medications, from their efficacy and management to supply questions to coverage decisions and the experience of individuals who are taking these medications. But today, we're really going to focus on the role of primary care, particularly how primary care is using these medications to treat obesity and meeting patients' self-defined goals. And how can other players that are interested in this whole arena, from employers to payers to policymakers, best enable primary care to fulfill this role? A few housekeeping items before we get started. This session, like all of PCC's webinars, is recorded, and we will be posting the webinar within 48 hours. You can find this webinar and all of our webinars on our website, thepcc.org. We'll also be taking questions. Please feel free to post them in the Zoom Q&A tool, which is usually found on the bottom of your screen. Panelists will answer those questions at the end. The chat has been disabled, but our team will be posting relevant documents into the chat, so take a look. Well, we're very committed to producing high-quality webinars exploring topics important to the primary care community. So after the webinar, please take a moment to answer our survey so that we can continue to improve on our offerings. Last year, PCC launched an initiative to assess how the primary care community can collectively move whole health approaches into mainstream primary care practice to really better promote the well-being of individuals and communities. You can learn more about our initiative on our website. Past webinars explore the evidence base behind whole person primary care and its business case. You can also see who's advising our work. We have a 15-member multidisciplinary work group that is terrific. And look out for a survey from us, because we want to continue to understand and monitor how our community is thinking about this topic. Finally, on June 4th and 5th, the PCC will once again have our conference. It's entitled Scaling What Works for Better Health. We're going to be showcasing innovators across employers, health plans, and policymakers who are advancing whole person primary care. This initiative focused on whole person care is generously supported by the Healing Works Foundation and the Ardmore Institute of Health. We're very grateful for their support. Now I'd like to introduce the webinar's moderator, someone who is known well to many of you. Dr. Mark Friendrich directs the Value-Based Insurance Design Center at the University of Michigan. And I see, Mark, that you're sporting University of Michigan swag there. He's also a professor of internal medicine and professor of health management and policy. Mark spent decades as a primary care physician, and so I think he really brings that understanding of the practice environment in his writing and his work. He also thinks in a big picture way about innovating health benefit design and how that can impact access, quality, and cost. He has authored a whopping more than 350 articles and books on this topic. So we are very pleased to have Mark as a moderator, and I will turn this over to you, Mark. Welcome.
Anne, thank you so much. And for your team, I could always count on you at PCC to bring together the most interesting and timely topics. And for you to bring together one of my favorite areas, whole person care and primary care innovation. And what many of us are thinking about on the clinical front is how we are dealing with the obesity epidemic and these very exciting yet expensive new innovations to treat unhealthy weight. I'm just extraordinarily excited to moderate this and to be able to introduce three fantastic panelists that are going to cover a lot of ground in a very short period of time. Our panelists include Christina Bell, who's a director at the National Alliance of Healthcare Purchasers, Jonathan Bonnet, who's an associate professor at Stanford School of Medicine, who specializes in obesity medicine, and Nita Crowley, who's a director of clinical education and partnership at SICA. And I know we're covering some broad topics here, and each of you bring a unique perspective to this discussion. Can each of you just give a brief intro about why these particular areas of whole person care and unhealthy weight management excite you?
Thank you so much, Mark, for the introduction. I'll go ahead and kick it off. So this topic is really one of the ones that is near and dear to our heart because we understand that primary care is at the center of our healthcare system, and 60% of services go through that modality. And, without it, I mean, there's a lot of care and individuals that would be lost. Um, Now, from an employer perspective, since, our organization works with a with coalitions over about, I would say, almost up to 40 coalitions across the United States, and their employer members, which represent 45 million lives. We also know that they're wholeheartedly looking for ways to support their members. And this in primary care opens up an opportunity for them to be able to do that. So this is something that we've been exploring specifically on the topic that we are here today to discuss on GLP1s and that integration to ensure that people are properly supported and treated holistically. So thank you.
Thanks, Christina. How about you, Nina? Really, really excited having met you in the prep up to this webinar to get to learn about your expertise.
Yeah, thanks, Mark. So yeah, I try to keep it short, but I'm a registered dietitian and health psychologist, and I work with patients with obesity for the past 20 years or so. I'm integrated with a lot of professional organizations. The one most relevant today would also be the Obesity Action Coalition of patients who have the chronic disease of obesity. And so that is a big passion for me, and what informs my work is doing the work we do for the patients, putting them at the center. And so now I'm lucky to work with a company, SICA, who makes body composition equipment. And so we're very busy and working towards getting our providers to do a little bit better, more comprehensive way to look at people's body composition and their ways to confirm excess adiposity. So we'll get into all of that, but I'm happy to be here, and thanks for having me.
Pleasure. How about you, John?
Yeah, it's really an honor to be here. I'm a family physician by training. I have some additional boards in sports medicine, obesity medicine, and lifestyle medicine. And my day job really is dealing with obesity medicine. But I'm at the VA, and our model really is whole person health or whole person care. And so I think, to me, obesity is one of those diseases that really does touch every aspect of health and of life. And so I think, for me, this is an exciting topic. One, because I get to spend a lot of time in it. But two, I think it has profound impacts on overall health and well-being. In ways that go beyond just medications or a simple disease condition. So I think wrapping all that up into the whole health perspective, I think brings a lot of value to the care that we deliver to patients.
Wow, I wish we had the whole day for me to pick each of your brains. But as I said, two really important topics, one of which is this using this term whole person primary care. Having practiced for almost 4 decades, I'd like to think I've been practicing whole person primary care, Christina, but I never used the term before. So for those who are unfamiliar, do you think you could give us a little bit of insight into the terms whole person care and whole health and what that actually means in practice?
Sure, of course. So one of the things I just want to bring up, I know that In 2021, the National Academy of Sciences, Engineering, and Medicines provided a new definition of what high quality primary care emphasized, and that was whole person and integrated. So when we look at this, when you think about the term of whole person primary care, there's literally like three components that we're talking about. The first one is approaching people holistically. We need to make sure that we're addressing the physical, their behavioral, social, economic, and their spiritual well-being. The second is comprehensive and multidisciplinary teams that are caring for them. So one, you have to make sure that the clinicians and nurses, and even it extends to the nutritionists, coaches, and the community health workers are there to support that individual. And then third, we're all working towards increasing wellness, right? We not only want to detect it, but we want to treat the disease. So we're looking to promote the well-being of those individuals and the communities in which they live in. And that focus is going to be around, what does well-being mean for them? So in asking or treating a patient, what is well-being for that individual? What is well-being for that family? And that is really trying to get honing in on what the center of care should be focused on. So I've seen PCC advocate for comprehensive care that goes beyond just treating illness or episodic visit, and to focus on the full spectrum of the individual's well-being. And I believe that when we talk about whole person primary care or whole person or whole health, it really aligns with PCC's mission in ensuring that care is not only integrated, but it's also tailored to meet the unique needs of each individual.
So that's terrific. And as you know, Christina, we go back a ways. We could be talking about holistic approaches and comprehensiveness and wellness in many clinical areas. But I think one of the reasons why we're seeing so many people on this webinar today, and I thank all of the participants for their time, is the fact that unhealthy weight and obesity has come to the fore. And, Nina, you've been thinking about this a long time, and we'll talk about GLP1s with John in a minute. But help us bring together these kind of broad, lofty goals of whole person primary care and some of the specifics that you've been dealing with around your career in nutrition and unhealthy weight management.
Sure. So I think one of the first things I'd like to say here is that when we're talking about the chronic disease of obesity, we're talking about the majority of Americans struggling with excess weight or excess adiposity, from however we're classifying it, and overweight, obesity, different categories or categorizations, and we have new ways to look at that too. But we've been dealing with not a niche group. This is almost all of us. And so it's really time that we start taking it seriously. And we have a lot of, treatment options. And so I think part of what's different and new about this era is that these new options are offering people a little bit more weight loss. And so once it's kind of crossed over that 10% of body weight, we're really starting to see differences in their chronic health conditions. And I think if we're talking to primary care clinicians, we're really wanting to, kind of highlight what the conditions are and how can treatment for obesity help these other conditions. It's all working together. I mean, even just today, chronic kidney disease is a new indication for medication. So the more indications we have for medications, the more I think legitimate, focus will be paid to this from all the different levels. So person-centered care, patient-centered care has been my focus, really putting the patient's values and needs at the center. That's also a big part of the three-pronged approach to evidence-based practice, looking at the best evidence at the time, the provider experience, but putting the patient at the focus. So I'm happy to see that aligning here with this group as well.
So John, you spent a lot of time taking care of patients with unhealthy weight. But I think it'd be great for some of the audience who are not in the trenches like you to take a step back and see Why is unhealthy weight, obesity, and particularly the innovation around GLP-1 have been so, one, eye-catching in the media, but secondary, why it's causing so much consternation to other stakeholders who are potentially looking at enormous budgets that would be necessary to treat the people in a way that you would think would be whole person?
Yeah, it's a great question, and it certainly is a fun time to be in the field. I mean, we've really seen obesity rates continue to rise at a pretty rapid rate over the last 50 years. And so, as was referred to earlier, I mean, it's about 73% of our country of adults who have overweight or obesity. And historically, our options have really been lifestyle oriented, which still remains the foundation of optimal obesity treatment. So this is your diet, exercise, stress management, improved sleep, support, mental health resources, all those things. All those things still really do matter and are really important. But if you look at the data for how effective they are in typically helping people lose weight, you're talking about 5 to 10% of body weight on average of all the major trials that are kind of out there. There are a few exceptions, but that's a pretty good ballpark, 5 to 10% via lifestyle changes. Now, if you look at historically the oral medications that we've had to use, which is really what we've been using for probably the last 50 years or so, again, you're roughly about 5 to 10% of body weight loss using the oral medications in combination with lifestyle. So to this point, we haven't really seen a profound effect above and beyond what was potentially possible with lifestyle alone. Fast forward to the advent of the GLP1s, and I will remind people the first GLP1 was actually liraglutide back in 2010, and its weight loss is actually not that impressive. It's probably about 6 or 7% of body weight. So this really wasn't until we saw the semaglutide come out more recently in 2017 as a diabetes medication that all of a sudden we started to see much higher levels of weight loss. So with the semaglutide, it's probably 10 to 16% of body weight, which again, if you compare historically, that's anywhere from 2 to 3 times potentially as much body weight loss as before. And now we have tirzepatide, which is anywhere from 2 to 4 times as much body weight at nearly 20-ish% of body weight loss. So these are really significantly higher amounts of body weight being lost than we've seen historically with medicines. And to give people a comparison, bariatric surgery is about 20 or 30% of body weight. So this is really starting to get into the same area or vicinity of a bariatric procedure that we can potentially achieve with medications over the course of a year or a little bit longer. And I think this has been a hot topic, one, because of efficacy. So certainly when people are losing a lot of weight, people pay attention to it. And we're seeing pretty impressive results just from trial data, but also just clinically. These do typically work well for a lot of people, although they don't work for everyone, and they certainly have side effects and problems. I think this has become a national issue because of the cost. I mean, these things are expensive, right? On the tune of potentially $1,000, $1,400 a month if I wrote a prescription and gave it to a patient to fill at CVS. Now, again, there are coupons and rebates, but a lot of people are struggling with, well, how do we pay for this, right? I mean, we can't just spend an extra, $16,000 a year on a patient to give them a drug that they may potentially have to take indefinitely. So there's been a lot of discussion of, well, is it worth it? Who's going to foot this bill? How are we going to pay for it? Clearly, they're providing a good service and people are losing weight and doing well on them. So what is that balance? And what is we, a country, are we willing to sort of say, we're going to pay for this because we think that there is enough value in it that it's worthwhile? So I think that's really the debate and the discussion, and figuring out how to do this, incorporate it into clinical care is where I think many primary care physicians are sort of at right now.
Thanks for adding a half dozen more things I want to talk about in the next 15 minutes, John. But let me just, before we get to those areas, I think what's been really interesting is that we've seen specific payers, public and private, cover these drugs only when aligned with other chronic conditions. So if you could just quickly take us through that continuum. We don't need to get continuing medical education. That'd be great. But I do want to make an interesting point about innovation. This is, something that Ann Greiner and I talk about a lot, is that in my work in the world of anti-obesity medications, the GLP-1 terminology has already been transpassed by the term incretin mimetic for weight management. So this field is moving so quickly that the term when this agenda was put together a few months ago is already kind of passé. So I will tell you that as someone who's studied many innovations over my career, this is one of the most exciting and perplexing for reasons that you state. But before we leave the clinical part, you're pretty good at paying comm, but I think we're really, really excited about this, not because we're seeing the weight on the scale go down, but the studies thus far are showing benefits that you and then Nina can chime in or just go beyond what we're seeing when we measure our pounds or kilograms.
Yeah, I mean, and this is what really excites me, and I think why my job is fun, because I think many times you're often seeing more and more conditions requiring more and more medications. You get a condition, you have 5 drugs that treat that condition, and you just rinse and repeat sort of day after day. For me, when you think about what are the drivers of all these chronic conditions that people have, I mean, fundamentally, insulin resistance and obesity to a very high degree and excess adiposity are really the primary drivers for most of the conditions, primary care, and honestly, that we face in the United States. So you can literally go head to toe with all the potentially negative impacts of adiposity. And so this is strokes, dementia in your brain. Obviously, you have sleep apnea as you're going down, acid reflux, heartburn, cardiovascular disease, dyslipidemia, diabetes, fatty liver disease, kidney disease, as Nina mentioned, osteoarthritis, chronic joint pain, but even gout in your big toe. So you can literally go head to toe. Vessels and basically every organ system is impacted in some way with this. And so to me, why my job is really cool is if we're actually successful in helping people lose weight, not only do pounds come off and fat mass goes down, all of these other chronic conditions get better, right? So to me, this is a much more root cause treatment than just giving a blood pressure pill and a medication for diabetes and for heart disease and everything else. If you sort of address the weight, all of a sudden blood pressure comes down, fatty liver improves, diabetes can be put into remission, sleep apnea gets better, joint pain goes away. So you really have this cascade of really profound effects. And if you can give somebody one drug and take them off 3, even if we are using medications, potentially there's some cost savings, but also to me, that feels like a better sort of scenario that I would want to be in as a patient. And this says nothing about the mental health benefits they get from being able to be functional again or do the things that they love and really enjoy their life and have the health that I think we all want and desire.
Really insightful, John. Christina, I'll get to you in a second, which is why many of my friends who are in the payer community have gray hair or haircuts like mine because they're extraordinarily stressed about the clinical cost trade-off. But Nina, you were taking care of these patients long before these miracle drugs came about. I'd like you to think about, obviously, where we're going forward, but spend a few minutes on like Back to the Future and the fact that I don't think I would recommend these medications to everyone who's been coming into my office begging for them, and maybe a little bit about lifestyle modification and other elements with or without medications that you think would contribute to the whole person management of this unbelievably common and morbid condition.
Okay, again, that's a lot to pack in there. So
Yep.
I think, one of the things I want to highlight here too is while the additional indications for conditions related to obesity has got attention, it does kind of highlight the fact that globally, we're not necessarily recognizing obesity as its own condition all on its own. And so that's an area that, we could spend some longer time talking about, but there is a lot of bias steeped into, policy and healthcare and all of this when it comes to, why can't it just be obesity? Why does it have to be obesity plus sleep apnea, obesity plus chronic kidney disease before we get recognition and coverage? So I think this does sort of tie into maybe Christina's expertise and yours with, how do we treat obesity seriously and get people the help that they need. And so as you mentioned, I've been working with patients with severe obesity on the spectrum who've had surgical treatment for several years. And so in that patient population, we see such an improvement in all of the health markers, in all of these, behavioral mental health areas. It's completely rewarding. And John, what makes my job fun over the years, similarly, is seeing how people's lifestyles can change. A big point that I want to highlight that I think should tie into primary care clinicians and this patient-centered or person-centered approach is that patients who have treatment for their obesity don't not do the diet and exercise and lifestyle. So I know this is a huge thing that the media has picked up on, and a lot of, to be honest, other healthcare folks who are talking to me like, oh, well, now that you're on a medication, people aren't going to worry about their diet and exercise anymore. And there's a lot to say in that topic, but the real focus that I want to leave you with is that it's an adjunctive treatment. It's in addition to, we're seeing a lot more collaboration between nutrition, exercise, behavior, medication, and surgery. It's not just a a bucket where you're one or the other. So there's a lot more talking between the groups who traditionally maybe only offered one treatment approach. But again, with primary care, you're the portal to being able to know what's out there and being able to offer these, and really being that voice to patients to say, you know, there are treatment options available. Let's work together to figure that out. Most of these are not one and done, and you do get you get to have this patient lifelong, which some of our other programs that have popped up over the past couple of years are really, they're missing the boat because they're offering quick fix, week-long programs that are not long-term. Primary care and management of a chronic disease is long-term. And so patients are going to go through different phases of their weight journey and their health journey where they may or may not need one or the other. We do want to make sure that our language is consistent with the evidence that this may be a treatment that you need to be on long-term. You may experiment with other ways, you may lose access, these types of things come up, but we want to make sure that our language is around, we're here for you for the long haul and exploring whatever those treatment options are going to be for you as the patient with your own set of needs and values.
Right on. So that's really interesting. So as we make the turn at the halfway mark of this hour toward home, so Christina, you get the tough part. So let me just say this. I'm sitting here with goosebumps that maybe you could see that from your population health perspective, which you have amazing experience and expertise, right? We are seeing holistic, we are hearing about comprehensive approaches, and we are hearing a focus on wellness. But one of the reasons I'm guessing that half of the folks in the primary care community are joining us today is because they know about all of these things, but it's been very problematic for them to practice the way they would want to practice. And this is not new in the area of obesity. I've been around long enough that I couldn't prescribe PPIs without H2 blockers and couldn't prescribe statins before bowel sequestrants and been dealing through this idea for quite some time. But I've never kind of seen a situation where your prior expertise and experience dealing directly with purchasers in Pittsburgh, and now your role on a national level, a real trade-off between when the door is closed, just about everyone tells me how they would love to cover these drugs, but they understand that it's just fiscally impossible to do so. And I know you're not speaking for the organization. I'm asking Christina Bell to say, like, how do you address this situation to try to appease the incredible demand and health benefits that come from increasing access to a multidisciplinary comprehensive approach to obesity management when it's almost impossible for people who aren't John to get their patients these drugs that they feel might be best for them? If you could turn your mic on, that'd be great. We don't want to miss a word. I think you're on mute.
Oh, there we go. There we go. So I was saying, thank you for the question. And there's so many ways that I have, looked at this personally, just as I know that I have family members that struggle with this disease. And the other thing is that I also understand the position that employers and purchasers are in. Because right now, I want to recognize that they have a difficult balancing act between a sort of the moral argument and the financial argument, right? So, from our perspective, I would say that employers have a lot of different options, and some of those in which Nina had hit on, and they should have these different options available. And from one end to the other, which is one, do we cover it? And cover it with guide rails. And I know that I've had conversations with employers who were looking for some type of guidance. And where the conversations have led to is that, all right, if it's with guidance, then let's look at those individuals who have a BMI greater than 35 or are at a comorbid condition. Now, that allows employers to really target those patients with the greatest need who are informed about the trade-offs and have a demonstrated commitment to be adherent. Now, the other thing, and I would say this is partly point two, is that, they enroll in a complementary behavioral change program that Nina was just mentioning, that these patients are willing to do that. I think there is a misconception there that they're not willing to exercise. They're not willing to change their lifestyle. I believe wholeheartedly that that is a myth, because we know that it wasn't until just recently that patients have tried and failed weight loss program after weight loss program and haven't had any success. So when GLP-1s came on the market, it really put employers in a difficult situation, because they have employees who were requesting it. And then they also are thinking about the greater good, supporting their employees on their journey to improve their health and their wellness. Now, along with that, I mean, we can't forget that there were already generics readily available to begin, that was, a part of a medication assisted treatment program. And these generic anti-obesity medications are not as expensive as the brands. So that is also an alternative that we can't necessarily overlook. Now, whenever I think about the cost, as Jonathan has mentioned, is that the costs are significant depending on which employer and what deal they're getting. This, like on average, is going to cost somewhere between $7,000 to $10,000 a year for a single person to be on a GLP-1 for a single year. For most people, that indication is that GLP-1s may be for the rest of their life, or at least for a very extensive period of time. It's not a 6-month course of care. So they have to be able to figure out whether they can afford that. And that's where employers and purchasers are. And, the perspective on average is that the cost employers about $25,000 to provide coverage to an entire family. So if you take that average number and then you say, we're going to add another 7,000 to 10,000 for a single person, for a single drug, that's obviously a very significant hit financially, and one that many employers find that they can't afford. So then, of course, that second option at the end of the spectrum is where they just say, we can't afford it, we're not going to cover it. And that's where a lot of employers are. But increasingly, we've been seeing, and I've also continued to have conversations with employers, that they are sort of creeping into figuring out how to find a middle ground, because they want to support their their employees and their families.
So I know I'm not a panelist, but I'm going to take moderator's prerogative for 1 minute, since the other panelists could say, Christina, you did not set me up. I mean, what you're really talking about here is my focus and why I need to learn from all of you. So first, a couple reactions from Nita's point. I think she implied, but it's important to say explicitly, that in their wisdom, and I say that with a wink, the U.S. Congress does not believe that obesity should be considered a chronic condition. And that is why, until very, very recently, any discussion about covering anti-obesity medications was never allowed. There have been bills moving for quite some time, and there's a Newsweek article, and great timing, out yesterday, advocating to build on the momentum for the U.S. Congress and the Medicare program to cover these anti-obesity agents. I have been very much in the weeds to this, Christina's point about how we're going to pay the $35 billion with a B. The Congressional Budget Office estimated to cover a small minority of people who might be eligible at the prices that you, Christina, and Jonathan mentioned. And I'll just say quickly that Maximilian's going to put in the chat a piece I just wrote for the incoming administration and Congress, that we could cover these things if, one, we get lower prices, preferably through competition, not negotiation, in my opinion. Second, very importantly, that people, in my opinion, don't need to be on these drugs for life. In fact, they should be on the expensive drugs during the active weight loss phase and let John and Nina tailor a personalized program to keep the weight off. And the third is that Medicare still spends billions of dollars that are not really good and too expensive, but things that I wouldn't buy even if they were free. So the idea that we're still buying VHS players in Medicare suggests that we should maybe not be arguing about how good our iPhone is and too expensive. So I will turn back to you, Nina, just kind of put the bow on the clinical discussion about the prevalence is always going to be an issue. There's always going to be too many people who want these drugs. And our projections show, even if they're less expensive, just the number of people, Christina, is always going to make your purchasers nervous.
Okay, so I think one of the big things to think about, I know here it's very interesting. We have payers and folks who are making policy along with our clinicians. For clinicians, I do think it's important that we are not telling patients this is something that you're on only for a temporary period of time, and then once you're done, diet and exercise can keep you sustained. I think that's important because that does sort of get back to more of a behavioral discussion than the biology. And I think what we know now is that the biology is such that there's people who, and I've had patients over the years who've had fantastic, beautiful diets. They've done more exercise than I could ever imagine, and they still were not able biologically to lose weight and keep it off. And so for them, it's a really beautiful way for them to have a change in biology to then be able to do the diet and exercise things that they've longed to do, that they've learned. They're not starting out with no information or education about that. They've just been unable to use those alone to lose and keep the weight off. So that's, I think, a big point there. And then I do think, for when we're thinking about, from a payer perspective, what are some of the other conditions that if you had 70% of your members with, and there was a treatment option that was really, I really don't like the word magic or miracle or any of that. I think that's what's caught media attention. But if you had a drug or medication that was as good as what we're talking about from an outcomes perspective for cancer, would we really be talking about regulating it in the way that we are for something that is as serious and connected to 200 plus health conditions?
Well, you really know how to be concise. That's terrific. I'm going to try to loop back now on the first part of the Venn diagram, which is whole person primary care. And John, as I ask you, one of the things I've written extensively about in areas not just the management of obesity are these standalone one disease internet companies. And as at least our patients in Southeast Michigan become frustrated, they are going online and getting compounded GLP1's, and many of them aren't even telling us about it. So I'd like you to take a step back to this conversation and say, PCPs are critical, right, for the reasons that Christina said early on. But the idea of relevance in an environment that's moving so quickly, particularly where in many situations they don't have the tools available to them to do what they and their patients want, read into the crystal ball. This is the answer I've been waiting for here. Like, I know you're not going to answer all the problems, but I think you could probably put us on a path to understand that we shouldn't give up the fight.
Yeah, I wish I had a miracle answer here. I think everyone would be quite impressed. It's complicated. It's not easy. I mean, I'm not doing primary care day to day anymore, and I'm certainly in a privileged position to be able to use these and have the resources. I mean, we have a dietitian, a physical therapist, a behavioral psychologist. We have a whole team, right? Most primary care physicians don't have that luxury, nor do they necessarily even have the time. So I think thinking about this through a primary care lens, I mean, even in my clinic, we're a referral clinic, so we get higher, more complex obesity. We obviously use a lot of medications. We even offer surgery and other approaches as well, in addition to, obviously lifestyle. But I think our relationship with primary care is really good. So they may send us our patients. We may work with them to get them on a good program, help them understand and adapt all those lifestyle behaviors. If they're on a medication, we'll get them to a good dose that's titrated well and they're tolerating. And then we can basically hand those patients back to primary care. So they continue to work with them, can provide some of those medications potentially, but then they're not also stuck with, well, I got to spend 6 months titrating this medication with the patient, dealing with side effects, dealing with prior auths, all those other things that really belabor a primary care's physician ability to do that. So I think for me, that's probably a big part of how I think primary care can be part of this. But again, there's also, we are really a team in medicine anymore. So this is using your dietitians, using your physical therapists, your behavioral psychologists, referring to an obesity medicine specialist if necessary, but also not forgetting about fundamental things. Like, again, just to reiterate, the lifestyle things are really important. And even if you look at the data for some of these amazing drugs, the most weight loss that we've seen is with doing a 12-week comprehensive intervention lifestyle medicine program first, having people lose 7 to 8% of their body weight, and then starting a GLP-1 drug after that. So this was with tirzepatide, 25% body weight loss, even more than what's seen by the drug alone. So I think when we're thinking about this, you do want to be thinking more holistically, not only about the weight loss results, but also, again, the overall health. And no matter how much weight you lose, it's not going to make you cardiovascularly fit. It's not going to help you maintain your muscle mass. It's not going to give you all the other benefits that a healthy diet, good nutrition, exercise, good stress management techniques, and good social connection are really going to have in terms of the overall impact on health. So again, I think it's good to focus on obesity because it does really have all these other comorbid related conditions. But I think at the end of the day, it's still not going to result in the health that we all want. And so I think making sure that we're still addressing all those other things is just as important as getting them on a fancy GLP-1 drug.
So before I get to Nina, though, I'm a big fan of the 100-Acre Wood and Winnie the Pooh. I'm pretty much a Tigger guy, and there are a lot of Eeyores out there. And I think that if you could just add kind of an additional crystal on that about why primary care providers, many of them are feeling Eeyore-ish about this, John, right? Because of the prior auths, because of the fact that people are going to online situations that they would be Eeyore-ish. Is there anything that you're kind of seeing and sensing that might be able to be a little more optimistic?
I mean, I think there's certainly reason for some pessimism. I mean, it is frustrating to deal with prior auths and insurance and get really bogged down with all of that. The compounding pharmacies will be going away within the next couple months because the shortages are gone and it's going to be illegal to do that. So whether or not people were dealing with that, that probably is not going to be on the table or a viable option, certainly in the long run. There is going to be competition. These medicines are going to get cheaper. There will be a day when tirzepatide will be like metformin. It will be generic, it will be very inexpensive, and it will be readily accessible and produced in sufficient quantities for many people to get. Now, that may be 10, 15 years down the road, but I think there is going to be a time and space where we actually have the ability to do this in a financially solvent way and also have the access and, again, hopefully the support and resources to do it. But I think when I'm thinking about a primary care physician, you're dealing with all of these problems already. These patients are already coming into your office. You've probably actually been exposed to or using GLP-1s for years, right? If you had patients on, Victoza for liraglutide or Ozempic for their type 2 diabetes, this is the same drug, right? So this is just a different indication for it. Now, again, different paperwork and whatever else, but I think primary care physicians are fully capable and actually educated and experienced. And to everyone's point here, the prevalence of obesity, we do not have enough obesity medicine specialists or lifestyle medicine specialists to tackle this problem, given how large it is. So it is impossible to do without primary care. So that would be my plea of saying, we need all of you playing whatever role and doing whatever you can to really help your patients.
Yeah, if anyone would allow me to use the heart emoji, I would send it up to all the hundreds of people around the web. Yeah, I learned all about the patient-centered medical home through this organization decades ago. So this is what you're saying is extraordinarily interesting. I think you're a bit naive about compounders going away, but maybe I hope that you're right. But Nina, I might have said something. I thought I knocked you off your chair, so I apologize for that. But one of the things that I find most interesting about this is that, we had statins come around, statins stayed around for a long time. I follow a investment firm that says there's 86 current new treatments, pharmaceutical treatments for obesity. So the goalposts, if we go back to the football analogy, are constantly moving. Not only are they moving in terms of what treatments I could use in primary care, but you were telling me the other day that the goalposts are also moving and who might be considered obese, who might benefit from any treatment or certain treatments. And, I've said for years that, personalized medicine does not have to attain only to things like cancer. I think the more we were able to tailor some of the things that the three of you were saying to individual patients, although my kids say I'm artificially intelligent, I think there might be a role for, learning models and artificial intelligence to be able for you and John to be able to say, this person should start with this, and another person based on what they have start with that. So if you could just kind of backfill a little bit about where things are going, about who might even be considered for an
Sure.
obesity management program, I think that would be very helpful.
Yeah, I've never been still this long, so the lights turned out on me for a second. So, so yeah, a couple things in response to that. One would be that we have recently seen the Lancet Commission come out with a report that's helping with the diagnosis of clinical obesity and preclinical obesity. So that there's a lot to say on that. It's a big report, 58 commissioners with 75 different medical organizations, professional organizations supporting it. There's also some discussion on, is that the right next step? So it's a step in the direction. And I think what you said with personalized and individualized care, that is person-centered holistic care, is really saying, what is exactly clinical obesity? Is it, what if someone just has excess adiposity and there's no implication of other, organs or disease states yet, sort of differentiating that. And I think the big take home that most all of us can probably agree with is that just BMI as a marker for if someone has obesity or not has been kind of under construction for a while now. And most provider groups, most clinicians are really moving away from that. But what we're seeing is, okay, if we're not using that to stratify and decide who gets care or treatment, what do we use? And so in my work now with body composition, we're really able to show, what is someone's excess adiposity? How much body fat do they have? Along with some of the clinical conditions that they have, we can better sort of decide what kind of care model they need, and not to regulate their care necessarily, but to sort of say, this person might have at a lower weight excess adiposity that's related to disease. They deserve care. And this person who, maybe has a heavier weight, but has a favorable body composition, maybe they don't have the different conditions yet. And so maybe we do a different approach for them, or start them with some lifestyle before we work on a medication. But, again, I think there is such an interesting connection to the policy and the insurers and the payers here. But I really think at the core of this, we've got to figure out for that one patient in front of you at that moment, what's going to be the next best option for them to get better care. And how do we define that from different markers? I think that's all probably what you all are really good at and can try to say, how do we decide who's worth it? I think that's a tricky question for a clinician. Is I think everybody should be part of that discussion and shared decision making. But when you start to decide who gets coverage for this, it's an interesting conundrum.
So unfair 30-second follow-up. Okay, for you, Nina. What about kids? Different, they're not just small adults. We've known about the childhood obesity problem in this country for decades. Just quickly, is this something that is somewhat more easily adaptable, these innovations from adults to children? Or is it something that you'd say it requires much, much more study and we should really hold back?
Well, I would say, the couple things would be prevention and all the things that we've thought worked don't necessarily have the evidence behind them to say they do. So instead of being idyllic and, idealistic to say, let's teach people to eat, star fruit in classrooms, that's not working. They do have health conditions related to their weight at younger ages. And so we do know from, lots of different studies over the years that earlier intervention for the chronic disease of obesity results in better outcomes. And this was very prevalent in my work with bariatric surgery, in that the lower weight, that's what I mean by earlier intervention, or lower weight and younger age were predictors of who did better long-term. And so that, with medication involved can help as well. And honestly, from a human and behavioral perspective, these kids are getting a lot of bias and stigma about their weight. So it's very nice when you can actually recognize and talk to them about, hey, listen, it's not your fault. There's a whole host of reasons. We don't have to identify what they are, but there's something that can help with this problem that you're having. not to take away the place of nutrition and exercise, but here it is, and let's work on this together because you're worth it.
Okay, so my late mom, who Anna's heard about a lot, loved watching game shows with lightning rounds. So everything we talk about now, we're going to have one round of 1 minute or so, 1.5, and then we're going to follow up with one last 1 minute where you get to say whatever you want as we're kind of dealing through some of these fabulous questions. And for some of you who are submitting questions through the Q&A, I apologize that we're not going to get to all of them. I'm trying to condense them into these final questions for each of the panelists. So, Christina, you're not only public health and population health expert, you're being viewed as the folks on this webinar as the keeper of the treasury. So I'm not going to tell you, not to ask you how we answer the healthcare cost crisis, because I haven't even made a dent in 35 years, but specifically around funding of primary care and seeing that this is really a key element, we all agree, in kind of moving the ball forward. Is this something, again, speaking for yourself, not your organization, that you could get behind in terms of advocating for this and trying to convince public and private payers, as I had for decades, that this is a worthwhile investment?
Yes, 100%. I think back to the bill that PCC has, and they have supported, which talks about providing hybrid payments for primary care practices. And so it would be a hybrid between a fee for service and a capitated program. Capitated payment. So when the primary care practices would get a capitated payment for the population, they would be able to charge a fee for service for some things that are above and beyond that. So I know that our organization has gone on record supporting that bill. And I personally also believe that, it is a bill that we should also be supporting, because it allows primary care practices to really invest in the kinds of things that we know that is working, right? And that are the things that are around whole person health, integration of mental behavioral health, and all that other stuff. So in addition to that, I would clearly go on record to say that we need to be paying a lot more for primary care in general. And we should be paying a lot less for healthcare overall.
Right.
But with primary care being the clear exception to that. The more we do in primary care sector, the more you keep people from getting sick. And we keep people from having much higher cost, complications, and certain specialty services. So I'm completely in favor with having commercial payers, Medicare, Medicaid, you name it, to pay more for primary care, because we have to have a primary care workforce, and we need to build that structure.
I'm sure Ann's team, in follow-up to all the attendees, will provide lots of resources about these specific bills and other things that you mentioned. So much to learn. But John, my chat started buzzing when I talked about this alternative approach to weight maintenance, and particularly your comment about what we're very familiar with in primary care is that sometimes we send patients off to specialists, to rheumatologists, cardiologists, pulmonologists, endocrinologists, et cetera. And we work together with them to manage these complicated chronic diseases. Again, I'm looking for you at the end of the rainbow, man, little unicorn, but any messages about how primary care might be able to work with obesity medicine colleagues like yourself, once we determine the treatment path, like we often do for malignancies, that we can own the patients long-term, not only with the medications, which are getting all the publicity, but all these other things that people seem to have forgotten about, that lifestyle, et cetera, that seem to be going by the wayside with this potential. You don't like the term, the magic pill.
Yeah, I think there are lots of opportunities and resources for primary care physicians, or clinicians, I should say. It really depends on your interest in sort of resources that you have. So I think obviously you can get certified as an obesity medicine provider. You can also look up all of the obesity medicine providers. We can provide some resources where you can search and find someone in your area that you can work with and refer to. Same thing with lifestyle medicine. You can get board certified in lifestyle medicine to help people make all those lifestyle changes coinciding with their weight management journey. And you can also refer them to a lifestyle medicine specialist if that's not, something that is of your interest, or, you have the time or resources to do it. So I think I would just empower people to figure out, where am I at? What is my skill set? What are my interests? And how can I best help patients, whether that's me doing that kind of care or me referring out to interact and work with a team so that the patient can get exposed to and has access to all of those things. Again, there's still a cost component here, and there's still insurance mandates of, can they be referred? Will it be covered? All of those questions still remain. But I think that's where at least I would start as a primary care physician.
You guys are so good. All right, real lightning round, 1 minute each. Nina, Christina, then John. So we all heard too much. I'm watching the four of you. I'm taking notes. I'm asking Maximilian to capture some things that I'm potentially missing. One takeaway that the audience might be actually an action item, not just an idea of a thought, an action item that say your life might be a little bit better in dealing with this area that we're getting crushed on, whether it be positively or negatively, depending on the perspective you have. One glimmer of hope. Nina Crowley, please.
So you don't have to do it alone. You've got other people on the team. I would say the comprehensive care approach, no matter where you're at in this area, the registered dietitians are here. We're trained. We are there to help. As John said, obesity medicine specialists, there's lots of different ways to tackle this. I think use of body composition in your practice is going to be the future. So figuring out excess adiposity and how you design your own approach to that is going to be helpful for not just obesity care, but aging and sarcopenia and all these other things. And take a curiosity approach and remember that, that person there in front of you is there because they need your help.
57 seconds. I didn't time it, but that's pretty darn good. Christina.
And the lights go out.
Bravo. And yeah, drop the mic. Christina, followed by John.
Yes, real quick. So for the employers and purchasers out there, please consider the full spectrum of obesity management strategies. But more importantly, look for opportunities to reinvest in primary care. Work with your partners to do so. The other thing I would add is that, providing affordable access to obesity treatment options and personalized care is, just foundational to workplace health. And in doing that, sometimes we do have to go outside of the box and invest areas that we previously did not invest in before. But obviously, coming out of the pandemic, our eyes are open, and please be open to engage in these conversations and make that investment.
Thank you. John, you going to close us out here? Thanks so much.
I'd love to. So bringing this back, whole health. My favorite quote when I think about obesity medicine: when a flower doesn't bloom, you don't fix the flower, you fix the environment in which it grows. And so when I think about obesity, I'm very guilty of being a flower fixer. There's nothing wrong with that. It's wonderful and needed and necessary. But if we're talking about addressing obesity as a chronic disease as a country, this must be a public health problem where we focus on the environments where we live, work, and play. We provide ample support for people to not only make behavior changes individually, but collectively as a community. And I think unless we are able to do that, we will bankrupt the country with every kind of medication under the sun, and we will still not get the health and happiness we all deserve.
Wow. Nina Crowley, Christina Bell, Jonathan Bonnet, and Greiner, thank you and your fabulous team, Sarah, Todd, Maximilian. I believe this webinar will be recorded so you could share it with your millions of folks in your network. And I want to thank all of you in the audience for your attendance and your questions, and looking forward to continuing this conversation with each of you. Thank you all and have a terrific rest of your day.
Thank you.